Thank you so much, Steve, and thank you everyone for joining us today for the webinar, Lesbian, Gay, Bisexual, Transgender Dementia Care, What We Can Do to Support LGBT Adults Living with Dementia. The National Alzheimer's and Dementia Resource Center webinar series is supported by the Administration for Community Living. And today's presenters are Arthur Chan and Charles Symes. Arthur Chan is the Lesbian, Gay, Bisexual, Transgender, Queer Project Manager and Family Care Specialist at the Alzheimer's Association in Northern California, Northern Nevada chapter. He provides care consultation and professional training and conducts outreach activities to the Asian Pacific Islander and LGBTQ communities to raise public awareness of Alzheimer's disease and other dementias. Before joining the association, Arthur worked as a clinical psychologist in the field of neurocognitive disorders in Hong Kong for 4 years. We also have with us Charles Symes, who works in the home care field. Upon entering the home care field, Mr. Symes worked under the compliance standards of a Medicare-certified home health agency until finding his niche as a home care organization providing high-quality in-home care. His company now serves 13 counties in Northern California. Mr. Symes' employees are proficient in LGBT aging and dementia services and are continually learning new and evolving methods in the long-term care and supportive services industry. Without any further hesitation, I will turn it over to Arthur Chan and Charles Symes for our presentation today. Arthur?
Thank you so much, Sari. Hi, thank you so much, Sari, and thank you everyone for attending today's webinar while we are all navigating through this uncertain time. I can't describe how much I appreciate the opportunity to speak with you about LGBT dementia care. So now let's talk about the objectives of today's webinar. So upon completion of this presentation, we hope that you will be able to list 4 best practices for LGBT dementia care, discuss issues that affect LGBT older adults living with dementia and their care partners, identify 7 dementia risk factors for LGBTQ older adults, and identify LGBT dementia resources. So now let's talk a little bit about the background of the LGBTQ dementia care project. So basically, the San Francisco LGBT Aging Policy Task Force released a policy issues and recommendations report in March of 2014. So from the report, 2 new LGBT aging programs were developed and put out for bidding. Those programs are Isolation Prevention Services for LGBT Seniors and Adults with Disabilities, and the other one is Dementia Care Project in Service to LGBT seniors and adults with disabilities. So you can access the full report by clicking the hyperlink attached. So our project proposal was eventually selected by the San Francisco Department of Disability and Adult Services, and we were given a 3-year grant in July 2016 to plan, develop, implement, and evaluate the LGBT Dementia Care Project and its training program. So the project is a collaborative effort that draws upon the expertise of 3 reputable, trusted nonprofit and community-based organizations. Alzheimer's Association is a leading voluntary health organization in Alzheimer's and dementia care, support, and research. And Open House works to center the voices and experiences of LGBTQ older adults in San Francisco Bay Area by providing opportunities to overcome the unique challenges they face and to make social connections and build community. Last but not least, Family Caregiver Alliance aims to improve the quality of life for family caregivers of adults with physical and cognitive impairments by providing support services, education programs, and resources. Because of the established reputation of these 3 organizations, many other community-based organizations have reached out to us for training and collaboration opportunities with the goal to make LGBT dementia care more accessible. So before I move on to show you parts of the training curriculum and what we did, I would like to show I would like to share some facts and figures about Alzheimer's disease and dementia so that you can get a better sense of what this is. So in the latest facts and figures published by the Alzheimer's Association, we found that Alzheimer's disease is the 6th leading cause of death in the United States. Currently, more than 5 million Americans are living with Alzheimer's. 1 in 3 seniors die with Alzheimer's or another dementia. It kills more than breast cancer and prostate cancer combined. And between 2000 and 2018, deaths from heart disease have decreased by 7.8%, while deaths from Alzheimer's disease have increased by 146%. So we can imagine Alzheimer's disease and dementia is definitely a disease burden and one of the medical conditions that we have to pay attention to. The other thing is that 16 million Americans are currently providing unpaid care for people with Alzheimer's or other dementias. So when we talk a little bit more specifically about the interrelationship between dementia and LGBT population, we actually know very little about Alzheimer's disease and dementia in the LGBTQ community. According to a recent study conducted by FLAT in 2019, surveying 3,165 LGBT and over 100,000 non-LGBT adults aged over 45 across 24 states from 2015 to 2017, the study showed that 1 in 6 LGBT adults, which is roughly 15.7%, reported subjective cognitive decline, compared to 1 in 10 non-LGBT adults, which is around 10.5%. In addition to that, there are several additional challenges for LGBT individuals. For example, LGBT individuals are more likely to report giving up day-to-day activities. They are more likely to report needing help with household tasks. And they're more likely to be interfered with social activities, work, or volunteering. So there is a major psychosocial impact of LGBT individuals facing cognitive decline or like having dementia and Alzheimer's disease. So now I'm going to introduce to you about the LGBT Dementia Care Project or the LGBT Dementia Care Training. So the training, actually we developed 2 modules. So for the Tier 1, the LGBT Dementia Care, which is around 3 hours long, and it covers the overview of dementia, LGBT prevalence, and risk factors. We also try to help participants understand LGBT people with dementia, for example, their functioning, their limitations, and the barriers to care. In addition to that, we also provided some better practices for working with LGBT people with dementia and LGBT caregivers. So for the Tier 2 training, we focus more on the effective communication strategies with LGBT people living with dementia. So for the Tier 2 training, it's around 90 minutes long. So the training covers communication changes throughout the course of dementia, and we help participants identify strategies to decode and respond to the verbal and behavioral messages delivered by LGBT individuals with dementia. So for the LGBT Dementia Care Training, our training participants are mostly healthcare and social service providers in San Francisco. In terms of like where the trainings are held and how it was organized, it's basically upon the request of the requesting organization. And we usually have the training at the requesting organization site. So sometimes we may also use public library or any other community-based organizations that are willing to share the space. But in this regard, these trainings are usually open to the public. So people who are not particularly affiliated with one specific organization, if they have time, they can come for the public training to further their education in LGBT dementia care. So usually for people who have any questions or if they want to request for training, they can reach out to me directly at my email. So in terms of trainers for the LGBT dementia care training, it really is a collaboration between the three organizations. So myself, EDL, Alex Morris from the Alzheimer's Association, Christina, Adriana from Family Caregiver Alliance, as well as Rochelle and Beck from Open House. We are all the trainers for this particular LGBT dementia care project. So we basically have a roster to determine who's going to do the training next and who would be a better fit for the organization and their needs. Okay, so as you can see on the slide, for our Tier 1 training, we usually begin with asking people to introduce themselves and their gender pronouns. The reason for this exercise is to help participants feel more comfortable with using and asking gender pronouns. No matter your gender identity, gender can be very important to someone's sense of self. To incorrectly gender someone can cause the person to feel disrespected or alienated. It is very important to know that we cannot visually tell about someone's gender. This means that we also cannot visually tell if someone is transgender, non-binary, genderqueer, or gender non-conforming. So asking for pronouns can prevent emotional distress from happening and also sets an example of respect. So as you can see here, there is this is a timeline of a list of significant events in the LGBT community. So as you can see at the very left column, there are different events. And in the right columns, you can see there are three different people. Maria, who's at age 89, Jose, who's 68 years old, and Sarah, who's 45 years old. So in this timeline, what I'm trying to illustrate is that there were a lot happening in the past 5 or 6 decades within the LGBT community. But because for Maria, Jose, and Sarah, because their age differences, how they view these events and their experiences could be very different. For example, Maria, as a lesbian, experienced all forms of legal and social oppression growing up. For example, LGBTQ people being banned from working in federal government, and she probably experienced Stonewall riots, which is police violence against LGBT community. Also experienced homosexuality, being stigmatized and being classified as a mental disorder. So for Maria, she went through all this legal and social oppression. So she doesn't really have much trust towards the government and any healthcare and social providers because of the traumas she experienced. But on the contrary, Sarah, who's also a lesbian, but because she's much younger than Maria, she might view all these events very differently. And she might have a different perspective about how the society treats LGBT community because she did not go through any of those traumatic events. So when I talk about this slide in our training, it's actually to raise awareness for people who identify themselves as LGBT people, but at the same time, just to remind them, don't make the assumptions that we know it all. We might cognitively know about all of these events, but we can't really, have the same emotional reactions towards these events. Take myself as an example. I'm a gay man in my 30s. I've never really experienced any blatant social or legal oppression. So even though I cognitively understand the pain the older generation suffer, I could not fully understand the emotions and what the impacts are. So this is another way for us to remind ourselves we have to be humble and we have to ask questions. Don't make assumptions when we interact with LGBT older adults. So when we talk about dementia, that is another thing that we frequently talk about. It's about the prevalence of dementia actually varies among race and ethnicity, being influenced by cultural and socioeconomic factors. For example, a lot of research has been conducted around race and ethnicity and its impact on dementia. So we found that African Americans are 2 times more likely than their white counterparts to develop dementia, and Latino Hispanic Americans are 1.5 times higher than white Americans, whereas Asian Americans are generally less likely to develop dementia among the different racial groups. However, because Asian Americans still kind of make up a generally small population in the U.S. nationwide, so more research is needed to find out exactly the percentage and the prevalence and what contributes to the lesser prevalence of dementia in the within the Asian Americans community. So here I'm going to talk a little bit about the unique LGBT risk factors for developing dementia. So for LGBT seniors, they were more likely to have dementia if they also had depression or heart disease or hypertension. And in addition to that, what we found is that depression, heart disease, and hypertension are general risk factors for dementia. But there is a higher incidence of these conditions in the LGBT community. So the LGBT community has higher rates of risk factors for dementia than the general population. In addition to that, compared to the general population, LGBT community has higher rates of smoking, lack of exercise, alcohol, poor diet, and all these are health conditions that are health habits that directly link to dementia. The other important risk factor is chronic depression. So there is an estimates of the prevalence of depression among older adults in the general population range from 1 to 5% to 6 to 8%. In a large community-based sample, 29% of LGBT older adults and 47% of transgender older adults have been found to have clinically significant depressive symptomatology. So as we all know, chronic depression actually plays an important role in developing dementia. So for the LGBTQ community, because of the higher prevalence of experienced chronic depression and other negative emotions, it's more likely for them to develop dementia later on. The other important risk factor that we usually pay attention to is isolation. So based on a study, 60% of LGBT older adults live alone in San Francisco, and they are 3 to 4 times more likely to have no children to support them, and 10 to 25% of the respondents cannot identify someone to help them in case of emergency. So the consequences of increased isolation are increased vulnerability and risk for emotional and physical problems. The other thing is chronic stress. As we all know, stress also affects our brain functions and potentially increase the risk for dementia. And the last thing is about HIV. For example, in San Francisco, it is estimated that more than 50% of people living with HIV or AIDS are age over 50. And this brings to the condition what we call HIV-associated neurocognitive disorder. So for people who who have HIV, 30% to 50% of them still presented with HIV-associated neurocognitive disorder symptoms. So here is another thing that we also have to bear in mind, is that intersectionality actually plays an important role in the, LGBT and dementia risk factors. For example, gay and bisexual men, compared to gay and bisexual men, transgender women are at risk, a higher risk for HIV. African American transgender women and Latino gay and bisexual men are particularly vulnerable to HIV. So when we talk about LGBT risk factors, we actually have to take a holistic view of it. The other thing is we often talk about when we talk about dementia is health disparities. So LGBT older adults are 2 times more likely to remain single. They are 2 times as likely to live alone, and they're 3 to 4 times less likely to have children to support them. So these observations and these data actually tell us, first of all, LGBT people are more at risk of dementia. And second, when they getting old or when they need help, they don't have the access to these social support or social network for assistance or for support. So these are the things that we always have to bear in mind. So people often ask, so what can organizations do? What can organizations do to provide or in creating a more welcoming environment for LGBTQ folks? So here are some points that you can do. First of all, educate your staff on LGBT cultural competency and expand your definition of family. So when we talk about expanding your definition of family, oftentimes in a traditional sense, family makes up of like a heterosexual couple and their children. But in the LGBT community, that's not the case. Like I said earlier, a lot of them are single, or a lot of them, like, they don't really have like connection with the family of origin, because especially for people in the older generations, a lot of time they're disowned by the family because of their sexual orientation or their gender identity. So in the LGBT community, the definition of family is quite different. So that's why we actually have a term. That's what we call family of choice. So family of choice means, you see your close friend or you see someone, that really close to you as family members. They might not have any sort of like, you guys might not be blood related, but those people are someone that you can count on when there's an emergency or when you're in need. So that's how we call family of choice. So family of choice is something that we frequently use to describe family within the LGBT community. The other thing that organizations can do is to use LGBT affirming languages, for example, like correct gender pronouns, avoid misgendering, and stuff like that. And the other thing is engage in LGBT-specific outreach, incorporate LGBT people into your marketing materials, so that when they look at your materials or when they look at your promotion, they at least get a sense that they are welcome and they are respected and they are welcome in the organization. The other thing is find or create support groups specifically for LGBT caregivers living with dementia, and also partner with local LGBT community groups, advocate for non-discrimination protections, and collect information on sexual orientation and gender identity. So a lot of people ask like, oh, why is this such a big deal? Why is it so important to collect information on sexual orientation and gender identity? Well, when we collect this data, it's pretty much like census, right? Like the reason we want to have this demographic information is that we can actually reflect to the local, state, or even the federal government that these people exist, and these people need help. And, they might be the silent minority, but they are here. They are part of our community, and they deserve, they deserve help and support like everyone else. So as you can see, here are some sample ads put in the LGBT media outlets and SF Chronicles to raise public awareness about LGBT dementia, and actually try to encourage people to reach out to us if they need any sort of support or information and referrals. So now let's talk about, what can individuals do? What can we do to actually help connect with or interact with LGBT older adults with dementia? So these are the things that we have to pay attention to. First of all, nonverbal behavior. So pay attention to facial expression and body language. As we all know, with dementia, as the disease progresses, a lot of people lost the ability to communicate with words. Sometimes they might respond to questions that are not fully comprehensible, and sometimes they just not be able to express their ideas or their feelings. So that's why it's important to pay attention to the facial expression and body language, all this nonverbal behavior. The other thing is we also want to make emotional connection with people living with dementia, respond to the feelings rather than the words or contents, because a lot of the time they say things, actually there are a lot of feelings behind. But because of the diminished ability to actually understand conversations, sometimes it would be more effective if we respond to their feelings and try not to argue with them or try not to reason with them or try to, talk through it, because sometimes it might not work. About emotional connection, the other thing is we should try to respond calmly to anger and other negative emotions, because a lot of the time is that when the person with dementia gets angry or gets frustrated, and we get anxious, and then we get angry, actually it doesn't do us any good. It's actually potentially create more conflicts, and it actually causes damages to your relationship with the person with dementia. So what I always encourage people and caregivers to do is that respond calmly to anger. Even though you're really angry, maybe just take a walk, take a break, and then come back to the person with dementia and then reapproach them. So that is another thing. Also, because people living with dementia, a lot of the time they don't have the sense of security, because sometimes some sort of familiar environment may become really unfamiliar to them, and oftentimes they don't know, they don't have the awareness of their surroundings. So sometimes it might induce confusions and insecurity. So oftentimes we have to keep on providing reassurance to them so that they can feel safe. So the other thing is about dignity and integrity. As we all know, even though for people living with dementia, they still have the strengths. They still have the remaining abilities. So don't just focus on what they cannot do or what they failed to accomplish. Focus more on what they can do and what they can still, help out on a daily basis. Try to focus on the strengths. And because a lot of the time, if you know the strengths, you can use the strengths to motivate them to do something for themselves. The other thing that is equally important is that do not talk down to the person. No baby talk, because it's like even though they might not be cognizant from time to time, or they might not be fully express themselves, but it doesn't mean you have to treat them like children. So give them the respect, try to preserve that dignity. The other thing that is equally important is that throughout the process of communication or the interaction with the LGBT adults with dementia, evaluate and re-evaluate. A lot of the time, evaluate what worked, what didn't work, and think about like how we can make it better, how we can make the conversation or the interaction smoother and easier for the person. Like I mentioned earlier, because sometimes it's kind of frustrating and kind of stressful working with people with dementia. So a lot of the time when you have any sort of negative emotions, try to ground yourself first. Check your mood. Ask yourself, why am I so angry? Why am I so frustrated? Can I do it differently? Would that be better? So try to pay attention to your internal emotions. And then once you can, work through those emotions, then you can think about any other solutions to the problems more effectively. The other thing that we also have to pay attention to is about the LGBT considerations. These items are particularly important to the LGBT older folks. For example, word that someone used. For example, for the older generations in the LGBT community, they have a very negative perception towards words like queer, homosexual, because the word queer means oh, you're different, you are deviated from the norm. And homosexual is a very medical term that used to describe the gay and lesbian community. And it has a really negative connotation, and it could potentially bring back a lot of negative memories and traumas. The other thing that we also have to consider is that the clothing people have been dressed in. That is particularly true and particularly important for people who are transgender, because for transgender folks, even though they didn't go through any surgery or hormonal therapy, maybe they have already been, for example, maybe a transgender woman, she has already been dressing like a woman and wearing skirts in the past 30 years. Just because the person later developed dementia, it doesn't mean we have to dress her in male clothes. So these are the things that we have to pay attention to. The other thing is we also want to remember the importance of connecting with people in their lives, because this is directly related to the point that I mentioned earlier about family of choice. So when we want to have someone to visit them, or we want to have someone to make some sort of care decision, we have to think about whether or not the person previously mentioned who to contact. So it's not necessarily the blood relatives. It could be some of the friends that they have been rely on in the past 20 or 30 years. So people who are important in their life are way more important than the blood relatives in this sense. And the other thing is knowing the history, because if you know the history, you know what they've been through, you can get a better sense of their likes and dislikes, and what would likely trigger the negative emotion, or once the negative emotions trigger, how we can be more effective in terms of calming them down and stuff like that. So here is the overview of the training outcomes in the 3 years of our project. So we basically developed 2 curriculum, and for the first tier, we actually went through some modification to make it easier for people to understand and to link LGBT and dementia better, so that people can get a sense how how the LGBT community, what are the unique challenges, and how these challenges actually prevent them from seeking help. So far, we provided 81 trainings with a total of 175 hours to 1,500 healthcare and social service providers. In addition to that, the trainings was also offered in Chinese and Spanish. In June 2018, we convened a Dementia Summit to invite organizations who have attended our training to report on outcomes and learnings and to collectively determine next steps in continuing LGBT dementia care. And in 2019, we formed an LGBT Dementia Care Network with the participation of community of over 15 community-based organizations here in San Francisco to have a focused conversation on need assessment and service coordination for LGBT people with dementia and those who care for them. So, in order to give you a better sense of the training impact, it's my pleasure to have Charles join in the conversation and share his thoughts on the training program. Charles has been an advocate for the LGBT Dementia Care Project, and he has invited us to provide the training to his certified nursing assistant staff and potential new hires in the past 2 or 3 years. So, Charles.
Good morning, and thank you for that introduction, Arthur. Yes, the training was incredibly important to me after I took the training. The first thing that I needed to do is to, not just only be part of the LGBT community as a community member, but as a leader in an organization that actually is providing direct worker services, direct care provider services. I felt it was really important to educate myself. And believe it or not, Arthur, my goodness, I learned so many different things in that initial training that I received through the Alzheimer's Association that I didn't even know that I needed. I thought I was pretty much in there. I thought I was active in the community. I thought I was really aware of different words and vocabulary and different ethnic particularities that were, part of a big city. San Francisco is, not isolated, really. You come in contact with all kinds of different people, and really the training was so important. And so as a result of that impact on my personal life, I did make it crucial decision to advocate for each of my direct care providers who had an interest in becoming involved with folks who are needing services in the LGBT community. Just like most populations, our workforce is comprised probably 10 to 15, maybe 20% of LGBT identified caregivers. So the vast majority of folks are not identified as LGBT community provider themselves, but that wasn't the issue. The issue is bringing forward the conversation, and so many of the caregivers have found the enlightenment of going through the training to be very, very useful in their day-to-day interactions with specifically working with LGBT folks with dementia in the home setting.
Thank you so much, Charles. That really put a smile on my face. Actually, I know that in addition to like 15 to 20% of your workforce actually self-identify as LGBT individuals, I also aware that a lot of the caregivers are actually coming from a cultural background that are more religious and relatively conservative. I wonder how they make sense of this training, or how they feel about providing care to LGBT individuals.
Well, one of the things that makes a caregiver so impactful in serving and working with someone else who needs help is that their personal desire to care is really there. So whether they have a strong religious background or a strong particular training, they're also a caregiver first, which means that they have to give of themselves. And so you spoke very quickly on the the meaning of being of cultural humility, and that when you start to break that down to being humble enough to receive the information in a non-judgmental way, really puts all of those other issues to one side. It allows you the freedom to go, okay, that is still part of me too, but here's another part that I'm opening my mind and my ability to reach someone else.
Thank you so much, Charles, for bringing back up to the cultural humility and being humble about learning the experience from others, right? Especially from people whose cultures are kind of different from us. So my another question is that what differences did the training make in terms of serving those in the LGBT community with dementia? For example, did your staff member feel more confident and more empowered about providing care and support to LGBTQ folks? Or they just think, well, it's just kind of, not that big of a difference, in terms of working with LGBT individuals versus heterosexual individuals?
It was a big deal. It really helped the caregiver have more confidence and understanding. And, we still make mistakes. But when it comes to gender and pronouns, that was something that we can really fix quickly. And, you will make a mistake, but if your client is able to help in the process of that, of making sure that the next time you use the correct pronoun, it becomes easier. And so we will do our best to prepare caregivers and give them the inclination and the tools of what they might encounter. But this training was so crucial because it allowed them to use humor, make a mistake, and then move on and recognize that they had a chance to do it again and to be better the next time.
Yeah, thank you, Charles. I think that's a very good point about giving them the safe space and giving them, the space to make mistakes, right? Because it's when we talk about changing habits or changing the way we interact with people, we can just change it within days. Those changes don't occur within days. It usually takes practice and it takes time. So I really appreciate that you kind of even think about here are the possible obstacles that you might encounter, and you kind of prepare them for that. I think that's very important. So my last question is, did you observe or have you observed any changes at the organizational level in terms of providing dementia-capable care for the LGBTQ community?
Well, since I lead my organization, I will take full credit for the changes that I did make. We did put positive images in place in all of our marketing, that this is a safe place that people could feel immediately rather than wondering if this was a safe place that they could come for care. We added visual cues such as language that is affirming, and with my husband being a graphic designer, we created our own version of something that was recognizable as an emblem of LGBT community. And we always make sure that there is both spoken and unspoken cues for a comfortable and safe place.
Wow, that's really awesome. Yeah, because you actually take extra miles, right? Like you mentioned, you even consider how to change your promotional materials, and in order to attract people and to help people feel comfortable and have the confidence in your home care providers. I think that's very important, especially for LGBT folks. Like you mentioned, all the different cues you use, right? Sometimes some of them may be more implicit, but some of them may be more explicit. So I really appreciate that you and your organization is trying your very best in creating and fostering a safe space for our LGBT older adults. So I think because of the time, it should be the Q&A session. Sorry?
Great. Thank you so much, Arthur and Charles. Fabulous information presented, and we have lots of questions coming in. And I'll just get right to it because we have about 15 minutes to answer as many as we can. The first question I want to ask of both of you is if you have any strategies you can recommend for direct care workers who serve the LGBTQ community, older adults with dementia in particular, who may have nonlinear memories that might switch between a time when they were closeted in their sexual orientation and then after they came out. Is there a way that you might suggest folks can address that?
Oh, I would really like to take that, if you wouldn't mind.
Sure.
You know, when the direct care provider is, part of their duty is to provide confidence and safety, and some things is not just task-oriented. I mean, there are other things that happen during a long period of time, for example, with someone with dementia. But you do have to be very careful with reminiscing. And you need in your own self as a direct care provider to perhaps have a creative spirit, to have some way to make sure that the person that you're reminiscing with doesn't go into the line of asking for specific details. Oh, really? Tell me about how difficult that was. Or trying to nail down the exact cause or the place or the time or the date. Those things are irrelevant. Reminiscing should be an opportunity to hopefully relive pleasant experiences. There will be times when unpleasant things come up, and perhaps just maintaining simple eye contact that's appropriate, being present, and helping them through a particular period.
Great, thank you. And Arthur, do you want to add anything to that?
I 100% agree with Charles, because a lot of the time, in addition to that, like, it's more about like how we can provide the emotional support that they need at that moment. So I think Charles pretty much gave a perfect answer.
Great, thank you. So Arthur, during your presentation, you talked a little bit about the use of the word queer with older adults with dementia. And a few people wrote in asking what word or words are better to use with older adults with dementia, since they may not be as accepting of the word queer.
Mm-hmm. So, you know, for the word queer, because of the negative connotation associated with it historically, usually we tend to avoid it. But with that said, for some older LGBT folks, if they have been paying attention to the later development or latest development of within the LGBT community, the word queer actually has been reclaimed by the LGBT community to like as a self-identification. What I mean is that people deliberately use the word queer to hurt us, but we own this term, so you know this word no longer means anything to us, and we can even use it to identify ourselves. So that is why for us to use the word queer, it really depends on the situation. Usually I tend to encourage people not to use it because you don't know how the receiving end would react to it. So in terms of what are the better words to substitute the word queer, just say, you know, if it's a man, you can say that, you know, are you like lesbian or are you gay, or just be open about it. because the more you feel like you're kind of like walking on eggshells, it's more likely that you're going to make mistakes. So just be open. You can even just ask them, oh, what's your sexual orientation? What's your gender identity? Some of them may have difficulty understanding these terms. Then you can like break it down as like, oh, sexual identities, for example, are you a man, or you self-identify as woman, or you self-identify as like trans woman or trans man. Just be open and give them some different options to choose from. That would be easier for them to get what you're asking of them.
Great, thank you. So, Arthur, there are so many questions asking if your training is available in virtual format. One, because of our current situation of people being at home, but two,
Right.
we have a lot of requests here and questions about if the training is available on the East Coast and how people can get the training. Do you have any plans to do the training virtually via webinar? Is this something that you all are considering at the association?
We are actually currently exploring the possibilities because, to be frank, for this particular training, because we actually received the funding from the San Francisco city and county government, so we basically can only provide the free training to providers serving within the San Francisco community. But we can definitely explore, the possibility of doing it through webinar. But the drawbacks of having a webinar is that throughout the training, the 3-hour training, we actually have a lot of discussion, a lot of interaction. So I'm not sure if that would be the best way to do it, but that is definitely something me and my boss and our project partners can think about. So if you have any questions, or if you're interested in having a training, regardless of not regardless, because we can do it in person. But if you're interested in having like a webinar training, please feel free to email me. We can, start from there and explore whatever possible.
Great, thank you. And I just put up the slide that has Arthur's email address so that folks can jot it down and contact him if you have additional questions about that.
Thank you, Sally.
Sure. Another question came in. I am trying to find it, sorry. Could you talk a little bit more about HIV-associated neurocognitive disorder? Some folks might not be familiar with it, and if you can give a little bit more information about what exactly that means, that would be helpful.
Okay, so HIV-associated neurocognitive disorder, which the abbreviation we call it HAND. So basically is that for people living with HIV, because of their viral load, it really depends on the viral load. So if the person has a high viral load, the virus may actually goes into the brain and cause some sort of neurocognitive damages. So, for people, if they have like heavy or a lot of viral load that goes into the brain, it might inevitably affect like their memory, their thinking, the decision making, the language, the planning, or the organizational or the memory abilities. So this is what HAND is about, like if I put it simply.
Great, thank you so much. Appreciate that. Can you talk a little bit about any observations or research you've seen about internalized oppression among LGBT elders with dementia? Do people with dementia get fearful about being labeled as LGBT? Can you talk a little bit about that?
Mm-hmm. Actually, when we talk about internalizing, a lot of the time I encourage people to Google minority stress theory. The theory actually illustrates perfectly how the person's identity, especially, it could be ethnic identity or it could be the sexual orientation, gender identity, how these factors play a role in influencing how the person perceives the environment and how they perceive the society in general. So from my experience is that some folks, for those who particularly experience trauma, like especially on social or legal oppression, a lot of the time they are very hesitant to tell you that they're gay or they're lesbian. For example, I used to have a client that I've been in touch with for several times. It's not until, the 5th time I visited him did he tell me that he's gay. He said to me, oh, and I just curious, I asked him, oh, why are you waiting till now to tell me? And his response was that, well, I didn't really know, if you would accept my, my gayness, like my sexual orientation, would you, think less of me? Or if I tell you, would you, whether or not you would treat me differently? So a lot of the time for LGBT older adults, they always have this chip on their shoulders. They don't know, if they should come out to their care providers or their healthcare providers. And that's why oftentimes we have a term of, going back to the closet. They came out, when they were younger, 20, 30 years ago as a gay person, but now because they are older and they become more vulnerable, they choose to hide their identity again for their fear of being discriminated and, negatively treated.
Great. Thank you so much. I want to try and get you to answer just one last question. I think both of you might be able to provide a little information about what individuals can do if they're facing pushback from organizations when trying to introduce LGBT inclusive measures.
Okay. I think. Sorry. Go ahead, Travis.
Go ahead, Arthur. No. I mean, if it were me introducing this as a priority, I would want the organization to think about how excluding them would impact their organization. Because if they don't include them, if you don't build the bridge more than halfway, even if you only get a few participants, what would it cost you for not including them? And that's a priority that somebody has to think about themselves. It's a choice.
Yeah, I agree with Charles. For me, because LGBTQ is something very personal to me, so I'm always being a strong advocate for that. But for organizations, sometimes they think differently, right? Even though if you tell them, oh, this is our social responsibilities, and this is the right thing to do, at the end of the day, they might just tell you, hey, well, I just care about profits. Don't tell me or don't talk to me about all this social responsibility, equality, mumbo-jumbo. So for people or organizational leaders who are particularly resistant for having inclusive measures for the LGBTQ community, usually I talk to them about return on investment. Talk with them about oh, is this a profit-making business? I know it sounds horrible, that we have to monetize this kind of thing, but for people who are really, really resistive for whatever reason, it's sometimes easier to motivate them on how much these inclusive measures actually bring profits or bring something, additive to the organization. And that would be a good start. Because once they invest the money or they invest the effort, you can build up on that. You can, think about more programs, think about more services, or if you don't have enough funding, you can think about, oh, if I can collaborate with other organizations who are passionate about serving the LGBT community so that it can kind of help you out, while you're navigating this kind of constraints.
Great. Thank you so much. That's actually all the time we have today. I want to thank you both, Arthur and Charles, for a wonderful presentation. We were thrilled to have you. And everyone, please take care. I'm going to turn it over to Steve for some final comments.
Thank you, everyone. Thank you, Arthur, Charles, and Sari, for a great presentation this morning. Yeah, it is time for us to wrap up, everyone. We've reached the end of our hour, but we do appreciate you joining us here for today's webinar. If you want to claim seat used